I'd like to invite Dr. Srinivas Kishore Sistla once again to the stage as a speaker on the session on the topic How I Do It, Tongue Base and Epiglottis in OSA. I'd also like to request Dr. Praveen Gopinath, Senior Consultant ENT and Head and Neck Surgery, Aster Medicity Kochi, to kindly chair the session.
Sorry guys, the background, the design is for this talk I gave in Brazil for the World Congress, so I couldn't change the design somehow. And now I don't have Sanu to keep calling for my technical problems. But all right. So now that you've seen the different ways of managing the palate, and these that Dr. Ranjani just showed are the latest in terms of palatal procedures. So the question is, will you do BRP for every patient, or will you do relocation for every patient? No, you won't. Obviously, there are phenotypes and endotypes in whom you would select. But unfortunately for us, palate is not the only level of obstruction. There are about 51% of patients on DISE who still have obstructions at the level of the tongue base. So you cannot shun away from that significant number. So if you were to do just a palatopharyngoplasty on all patients of OSA, you would still have 17 to 33% of the patients having residual disease, right? So here if you see that there is 51%, and here you see 33%. So there is that 20% there. That's probably number coming out of overscoring your DISE. And why that happens, we'll discuss in the afternoon when we talk about DISE. All right? So if you were to do just a palatopharyngoplasty for all your patients of OSA, you will still have about 17 to 33% of patients having residual OSA because of obstructions at the level of the soft palate. Now, just as you do palate, you have to also look at and classify how your tongue base is causing an obstruction for your patients, right? So you need to differentiate it into three basic phenotypes. Number one is the macroglossia patient, all right? The patient with a big tongue. Now this big tongue can be because of two reasons. One, it could be lymphoid hypertrophy, the one that we call as lingual tonsils, which is the low-lying fruit, which all as ENT surgeons would like to have because it's easy to treat. Or you have the huge muscular tongue base, which we call as a high tongue base, that is absolute macroglossia, all right? The second phenotype is the relative macroglossia. The tongue is looking big because the jaw is small, right? And the third is the tongue is falling into the airway because of two reasons. One, like I said in my earlier lecture, the tongue has no space to sit in the oral cavity and hence falling back, or the muscle responsiveness of the genioglossus muscle is not strong enough to keep or withstand the negative pressure in the pharynx, right? So basically, once you have a patient with tongue base, you need to understand as to whether it is macroglossia, relative macroglossia, or tongue falling into the airway because of these two basic problems. Now, most of us are really puzzled by this particular word, which is taking the dental world by storm, and all of us are also seeing patients that are coming to us for second opinion. Now recently there has been a publication that has actually said that ankyloglossia when you call it ankylosing, you shouldn't be using the Kotlos classification. What is the Kotlos classification? That is that when you keep protruding the tongue out. No, do not use that because the wrong metric of measure. The metric of measure you should use is the TRMR, the tongue restriction scale, wherein once you ask the patient to touch the upper part of the inner aspect of the upper teeth and then ask the patient to open the mouth. Based on how much you are able to open, then you grade it as 1, 2, 3 and 4. If you have restricted tongue mobility, definitely there is a problem there. Why? Again, because the tongue has to always rest in the upper part of the hard palate. If it takes a lower posture, also known as low tongue posture in the oral cavity, where can it go except into the airway? Hence, it is important that ankylosing has to be checked when we do evaluation of the upper airway. Yeah, sure. So let's deal with each phenotype at a time. So no marks for guessing this. This is obviously lingual tonsils, right? So when we see this, it gets a smile onto the ENT surgeon's face because we can treat this. Now, when we treat it, the newer coblation halo wand has an advantage here. Why? Because the biggest problem with EVAC was that it was getting blocked. Because this has a huge suction port and it has a circular footprint of the electrode, it takes more tissue off and it doesn't get blocked. So what is the aim of your treatment? Your aim of your treatment should be to completely clear off the vallicula of the lymphoid aggregates. Now, you should be very careful in this area because the mucosa on the lingual surface of the epiglottis is very redundant as opposed to the epiglottic part of the laryngeal part of the epiglottis. So, when you have a lot of suction, the mucosa keeps getting sucked inside and then it can cause bleeds. Another thing that you need to be wary of is the return. When you put in the high setting of the werewolf device with a halo wand, the return electrode behind is also active. So while you're doing the ablation, the return electrode is actually helping you in achieving hemostasis. So very different from the regular C2 coblator, the halo is much of a touch technique. Now all of you are using coblator, right? And all of us are used to the typical paintbrush kind of using the coblator, and we have all learned that technique. But werewolf changed all that. This is more of a touch technique, and it basically even gives you that kind of a feel, but you can still use the plasma, but it's almost you have to touch it if you are able to see. Now, what is also happening behind, if you look at it, you see the return electrode? That's also cauterizing the tissue, so you need to be very careful. Another care that you need to take is at the junction there, where the pharyngoepiglottic fold is there, is the epiglottic branch of the lingual artery, and there it can bleed. So we need to be careful. So at the end of the procedure, you want the vallicula to be completely cleared. The same thing can be done in kids as well, because one of the commonest causes for residual OSA or recurrence of OSA post-adenotonsillectomy is lingual tonsil hypertrophy. The aim should be that you need to clear off this whole thing. So that's why I just paused it at that area. That's the thing with the lingual tonsil there, and the complete vallicula is cleared. My problems have started. It will come. Yeah, that's why Mac is better, but somehow I don't like. The second phenotype is the absolute macroglossia. The absolute macroglossia. So how does absolute macroglossia look? Once you look at the MRI, it looks massive, and you can see these very thick rugosities, tongue scallopings that are basically suggesting that, the tongue is very massive. Now, once you want to do a muscular tongue base, there are two things that you need to be careful of. One, and the most important, is the neurovascular bundle. So the neurovascular bundle is located 2.7 centimeters inferior and 1.66 centimeter lateral to the foramen cecum. So what does that equate to? It equates to the footprint of your EVAC 70 wand. So you can use that as a measure to know how deep or how lateral you are. Another word of caution is when you are in this area posterior to the circumvallate papillae, you are very safe. You are not going to damage the pedicle. But a word of caution again. When you protrude the tongue, the dorsal branches of the lingual artery come closer. So that number becomes lesser. So you need to be careful when you protrude the tongue forward. And that is what the other picture is showing. So there are many ways to skin that. There is a transoral resection versus ablation. This is from Yasin Bhagat, from Claudio Vicini group. There is cell, there is smile, there are lots of techniques. But it's not about the technique. It's about the fool behind the tool. And I always say that. So they've done a meta-analysis to know how safe are the tongue-based procedures that are being done, right? And they found out that if you were to do just radiofrequency ablation, your chance of having complication is only 4%, as opposed to if you do a heroic midline glossectomy, your chance of success or having complication is 4%. The higher the chance of complication, the higher your success rate. But the advantage of doing with radiofrequency is that you can do it at multiple times and you can use this as an OPD measure after and again, maybe 3 weeks apart. And it has been shown that multiple applications of radiofrequency to the tongue base does cause volumetric reduction of the tongue. The same thing, we can do it in the form of what we call as smile, which is an endoscopic approach wherein 1 centimeter anterior to the foramen cecum, you dig a tunnel and you core out the tongue. So as you do that, what happens is the canopy on top of that tunnel just collapses because of the fibrosis, and hence there is reduction in the volume. Now, when you have major tongue bases, like how I showed in that lady before, you may have to do big resections, right? Big resections, when you do, you probably will need either a ProSize Max wand or you will need a Halo wand. if you see, we've done massive resection for this patient, but what you see there is that there is no endotracheal tube and this is not cadaver. It's basically telling us that when you do massive resections, it's probably a good idea to trach the patient just to have control of the airway, because the next day, no matter how much steroids you give, there will be some amount of edema. This is again another very similar way of doing. This is midline glossectomy with halo. For want of time. So again, you want to completely clear off the valvula. The technique is still the same. Now, most of us would think we have some nice, cool robots. Most of the hospitals have robots nowadays. So how is your coblation, how is it facing up to the Goliath? Because obviously coblation is David, right? So if you want bang for the buck in terms of value, it has been done. I'll show you the synopsis of the study. In comparison, TORS and coblation, we found TORS to be as effective as coblation. That means coblation is as effective as TORS. Now, the advantage here is cost, number one. Number two, when you are using monopolar diathermy with the Da Vinci machine, the collateral damage is much more. So when you're already getting the same amount of resection, you should probably think, unless you want to be cool and get onto Insta and show off, probably this is also going to give you decent results. And there are lots of studies showing very similar kind of results pre-op and post-op. The third phenotype is the relative macroglossia, which obviously you will need to work along with your MaxFax colleagues to give good outcomes. Either you do a mortised genioplasty or an advancement genioplasty. So you do a soft tissue procedure and team up with your MaxFax colleague to do the advancement genioplasty or mortised genioplasty. The fourth is the tongue fall into the airway, also known as coupling. This is a middle-aged woman, this is a middle-aged man. That tongue can definitely not fit into that oral cavity, obviously. So even if you do a midline glossectomy, this is not going to work. So that is the reason why we need to have different phenotypes. And thanks to the work done by Stanley Liu in Stanford, he's not there anymore. So this is how the classical cases are. You can see that the dimensions are very low. And that is the reason why we need to be very clear as to look at the nose. It's an isosceles triangle instead of an equilateral triangle. So this is how you measure it, and this is how you can do it. I think Dr. Sukhinder has an entire lecture on that, so we're not going to do that. Post-op, this is how it is. And this is the post-op study from 73 to 13. But, like I always say, MFT, myofunctional therapy, very, very important. So, it is very important that you put the patient on myofunctional therapy post any upper airway. Let them also earn their treatment. It's not you give. Let them also earn their treatment. It is also important that you tell them that, look boss, I have done my part. Now you do your part. Only then we are going to succeed. And be very careful of patients with unrealistic expectations. The patient might be thinking when you do tongue-based surgery that he's walking like that, but he probably, it's important that he needs to understand that post-op, when you do tongue-based, it's very important that you are walking for a few days at least on a bed of thorns. So it's important to set their expectations right. Thank you very much. I know I missed on the epiglottis, but I will do it when I talk about the residual OSA.
Thank you, sir. We'll now have a minute for any questions.
Yeah. where coblation comes in. Coblation helps us to sort of reduce the pain score because it's very gentle, it's controlled ablation, and the pain score is far less than actually the palate itself. So, and if you do a smile procedure, like the one that I showed, like day before yesterday we did one smile, patient is off. In fact, the palate and the tonsil is paining more for the patient than the tongue base. So this is see, all of us are experts in endoscopy. Smile is an excellent procedure to do.
Sir, what about radiofrequency?
Sure. So radiofrequency tongue base, you can do it through coblation or you can do it through radiofrequency devices. You need to put in a minimum of 6 based on the surface area that is available. You need multiple sittings. One sitting will not give you the result. But at least 3 sittings if you do, there is a lot of data to support that it causes volumetric reduction. But make sure that the box is big. If the box is not big and you do radiofrequency, it's not going to give us the result.
Thank you, sir. Further questions can be asked during the post-lunch session.